Carlo. So we'll now go to Mr. Van Bynen. Mr. Van Bynen, go ahead, please. 6 minutes.
Great. Thank you, Mr. Chair, and thank you to all of our witnesses for joining us today and sharing their experiences and their concerns with the pandemic. It's a great honor to be able to welcome a constituent to the committee and have their voices reflect in the work that we do here. So I'll be directing my questions to Rebecca Shields from CMHA, York Region and South Simcoe, and acknowledge that she serves a population over 1.2 million people across more than 10 different municipalities. Firstly, Rebecca, I want to thank you for the many projects that you've undertaken in conjunction with community partners like York Region Police, South Lake Regional Health Center, and how you put together teams to respond to situations that are urgent and often call for police presence, but also has the presence of your team so that you can respond effectively to these. Now, last fall, I moved a motion in this committee to study the impacts of COVID-19 on mental health and the well-being of Canadians. And that was well more than 4 to 5 months ago. And I referred to mental health as being the third pandemic, and it's become the fourth pandemic now. And I very much understand what your concerns are. You supported the call for this study and said that to achieve full economic and social recovery, we must understand the true impacts of the pandemic on mental health of Canadians. And I completely agree with you, and I thank you for that support. I know that it's critical to invest in comprehensive community-based research to understand the impact and identify the most promising strategies. And you made some references around hotspots. While this committee has the scope and the scale of this committee is more broadly countrywide, what would you suggest we would take, or how would we go about trying to identify the community-based strategies?
Thank you so much for that question. It is really true that each province and territory addresses healthcare differently. However, mental health affects us all. But we do have unique community needs. And this is what we're seeing. So, at the very basic, when we understand that COVID, which is a healthcare issue, impacted different communities differently. Same disease, completely different impacts and outcomes. So what we're learning from the research of COVID, we have to kind of translate that into local neighborhood-based research. We can pull data from our hospitals around, and we do, and share that information. But what does it mean to have population-based research? Well, there's very many components of that, and there's some great leading practices coming out of, for example, the Slate Center at CMHA, where they're looking at youth-specific research. One of the things that they're sharing is in co-design and co-participatory research is how COVID is impacting youth differently. Not all cohorts of youth are the same. Some might be thriving at home, and then the Honorable Mr. Mitchell said, or my colleague Mr. Mitchell said, some are not. And how do we understand and address that so we can be designing and delivering services that are effective, and so that we can take a health equity approach? So in community-based research, that what we want to have is we want to have the lens of health equity across that research, and then to be able to co-design and deliver services that are effective for those communities. So the research must be embedded in community. It must be co-designed. It must take into account a population ethnocultural lens so that we can have a health equity approach, as well as other cultural specific groups, like my colleague Mr. Leslie said, developmental disabilities, 2S LGBTQ, our Indigenous communities, our Black communities. All those communities have their own needs, and so as we design and break down research, we need to not just stay at a global level, but really take the investment to dig a little bit deeper, because we know that responses must be designed in order to meet specific needs. And the pandemic has shown us this. If we do not take into specific populations, they get left behind. And without that health equity lens, they're disproportionately impacted. And so we can do better. And that's what I'd like to see us do. Thank you again for your question. I hope I responded.
Thank you. The access to mental health resources and supports has been key during this pandemic for many Canadians. And our government has stepped up with the Wellness Together Canada and the Kids Helpline. And I know that CMHA had their own telephone-based supportive counseling. My question is was this a service that was in place pre-pandemic? And if so, can you elaborate on the changes or the differences between before and during the pandemic that you noticed or that your staff has noticed?
Sure. Well, first and foremost, obviously, like all mental health agencies, we switched to, as much as possible, virtual care. So that allowed access to people. And again, I did mention that we do need to ensure equity of access. But what we did do is we offered specific counseling for frontline healthcare workers. We offered a variety of just walk-in, so really trying to take away any sort of wait list, so a lot of like walk-in or call-in services in order to address immediate needs. We expanded the access to the bounce back program through an investment so that we could not have anybody wait for that over the phone based cognitive behavior therapy that addresses, it's an evidence-based form to address worry, low mood, stress, and anxiety. So those are the type of investments that we made to quickly address population health. And then we did deeper dives into specific vulnerable populations like our homeless population. I see the red card, so thank you very much.
And thank you for all the good things you do for our community.